Chris Haley. Chris Haley is a pain specialist in Kingston Health Sciences Centre in Canada. He trained in medicine in St. Andrews University, Scotland, as well as Manchester, and then went to Canada and trained further to become a consultant at the Kingston Health Sciences. In addition to pain management, he has an interest in quality improvement and teaching, and he is also a sub-editor for the pain section of the World Federation of Societies of Anesthesiologists Tutorial of the Week. Now, his topic is particularly interesting to all of us, and cannabis use, probably, I think I'm reasonable in saying that all of us will have encountered in our pain clinics, oh, I want to try cannabis. I've tried cannabinoid oil. Can you just sort of endorse it? And we have a bit of a problem here because we don't have enough experience. So I welcome Chris to give his talk and enlighten his experience about use of cannabis in Canada. Chris.
Thank you very much, Sanjeeva. Thank you very much, first of all, for allowing me to talk today. It's a real pleasure, having trained in the Northwest, to be able to have this opportunity to talk to everyone here. I've been a pain physician in Canada for about 4 years now, and the legalization of cannabis has been around for about 3 years, so it falls under a similar jurisdiction as tobacco and alcohol now. So obviously a lot of people that we have who come into the pain clinic have either tried it recreationally or they are looking at it from a pain perspective. So I'll just give you a little bit of an insight into what I've found in the last 3 years with people coming through our clinic. So again, just to get this out of the way, I have no conflicts of interest and no commercial interest in cannabis or any cannabis products. Just to repeat how I got to where I am today. So I started in St. Andrews, and then I finished my medical training in Manchester. I then moved, got my Royal College and did a couple of fellowships, one in medical leadership and then also one in pain in Salford and Penn and Acute Trust. So shout out to everyone working in those institutions. And then I wanted to just experience a little bit further. So I went to Toronto and did my training in St. Michael's Hospital in Toronto. And I had quite a bit of experience with the transitional pain group, actually, with Hans Clark and his group that Emma talked about just earlier. And then decided to stick around here. So then I got my, went to Queen's University, which is in Kingston, Ontario, and I'm here now. And there I did all my Royal College and all my licensing to become an independent practitioner here. So this is where I'm based right now. So it's about 3 hours east of Toronto and 2 hours west of Ottawa. So just in the middle between the two. Although it's 3 hours east of Toronto, it's still on Lake Ontario, a massive freshwater lake. And as you can see here, this is our hospital on the lake shores of Lake Ontario. So what I wanted to talk to you about today was basically a quick overview of what cannabis is, the current forms that we've got available here in Canada, both medical and non-medical, how it affects the patients and how it affects not only just the pain side of things, but also me as my other hat of being an anaesthetist and how it affects us in the acute post-operative period as well as the perioperative period for pain management. And then just give a few insights into how we use it in the clinic, or if at all, or and how it affects the way we have to approach people on an acute pain service point of view. So for everyone, I realize this is the end of the day for you, the beginning of the day for me, but it's this is the sort of the take-home slide, and lots of papers have come out over the last few years, but this one seems from 2018 seems to summate pretty much where we are in terms of cannabis. So this was a multi-center trial. So this was a systematic review looking at lots of all the evidence that came out about cannabis products. And the real take-home message, which I'll go on to a little bit later, is the NNT and the NNH. This was one of the first papers to actually come up with numbers in terms of the numbers needed to treat and numbers needed to harm. As you can see from the summation slide here, the pain outcomes, it was not significant for pain reduction of 50%. It was significant for pain reduction of 30%, but this was the numbers needed to treat here was pretty high at 24, whereas the numbers needed to harm for all cause of adverse events is around 6. So you can see it's really heading towards the numbers needs to harm side of that equation. Most recently, the other place that I find a lot of great evidence or summation of the most up-to-date things is the Pain College from Australia and New Zealand, and they've just released their 5th edition for the acute pain management. And again, if you look at section 2, question 2 there, it says that current evidence does not support the use of cannabinoids in acute pain management. And the same can be said for chronic pain as well, with the proviso of the long-standing knowledge about MS pain and also HIV neuropathy, which I suppose is less of an issue now with our new HIV treatments. So let's just go over a quick view of what cannabis is. So it goes by many names. It goes by and it's been pervasive through North America in terms of popular culture, but it really goes back to Mesopotamian, Egyptian times. It's been around. It's one of a very old drug. Known as marijuana, hashish, lots of other terms. It's 2 main components that we deal with and that we talk about when we're talking about cannabis is the THC, the tetrahydrocannabinol, and the CBD, the cannabidiol. So those are the 2 components that we talk about. The CBD being both working on the CBD1 receptors, which are in the brain, but the CBD part not having the psychotropic sort of high effects of the THC. Cannabis can be a hallucinogenic and also produce feelings of well-being, which is why obviously people enjoy taking it recreationally. Generally, it's considered not to be dangerously addictive, but dependence can occur. And so people who are on it chronically, especially in high doses, will develop some feelings of withdrawal if stopped. Now, chronic use, there was this talk of it sort of precipitating psychotic disorders such as schizophrenia, and that's one of the reasons why it's been thought to be problematic in the younger developing brain. I think the evidence is currently out. What it seems to do is it seems to maybe unmask underlying mental health issues such as schizophrenia at an earlier stage than maybe it would do if people weren't taking cannabis. But it's certainly something that we do keep in mind. So if you look here, this was pre-legalization in Canada. So the lighter areas being the prevalence of cannabis use throughout the globe. And as you can see here, the 2 years before the legalization of cannabis, North America really did lead the charge in terms of prevalence, in terms of its use. I think a lot of this came from, again, more social reasons, being very close to America, the United States of America, where the prohibition laws and alcohol limits being at 21 meant that the use of cannabis was used as an alternative to alcohol as one of the main recreational drugs. So and we've had medical cannabis for quite some time, long before I started in my practice here. So there has been quite established medical routes for cannabis, and I'll talk about those in a second. The main reason why it's very hard to find evidence, and there's lots of different ways of looking at cannabis, is the fact that the actual we're talking about a herbal drug here. So unlike our purified medications that we use in clinics today, cannabis is a derivative of a complex plant with 400 different chemicals, 60 of them being cannabinoid products. There's different strains, there's different hybrids, there's different types of cannabis, and the way it can be taken varies wildly as well. So in the same way about the effects of, say, IV morphine compared to oral morphine or an extended release preparation, the route, the type, and there's so many different factors coming in, which makes it very hard to tease out the actual effects on what's causing what. Currently in Canada, we've got 3 main forms of medical sort of medications. And by medications, I mean things that have a DIN number, or drug identifying number. So the first one, and the one that we probably use the most in our pain clinics, is nabilone. So this is a synthetic THC molecule originally used for chemotherapy-induced nausea and vomiting. However, more recently it has found a place being used in fibromyalgia patients. Usually it's between 0.5 to 1 milligram twice a day. It's used initially for sleep, and people do seem to find some benefits from this. We also use it from a logistical point of view, because cannabis itself, being under the tobacco and alcohol laws, means that it's very rarely covered by drug plans. And so because this is a DIN number, it is covered by drug plans, which means people have accessibility to it. Another form of cannabis that is more the medical version is Sativex, which is THC, but also CBD as well, in a 1-to-1 ratio. This only has quite limited approval in Canada, and again, it's for those long-standing known benefits of neuropathic pain in multiple sclerosis, and also used for some cancer patients. But this has been around for about over 10 years, and it's still quite it's a very expensive drug, and it hasn't come down in price since the legalization has occurred. So it's not used regularly in hospital by ourselves in the pain clinic. And the third one is, we've had a THC, we've had a mix, and now we've got the cannabidiol, the CBD only drug, and this only came out in 2018. And this is, again, very specific usage in pediatric patients with specific seizure disorders. So again, nothing that would be a common prescription. As I said, we know that we've had legalization of cannabis in Canada since 2018, and I think the drivers for that are numerous. One is its pervasive nature, and like all things that are pervasive, if it exists anyway, then let's tax it, and so it became legalized from that point of view. The other reason is because of the opioid epidemic, and my previous presenter actually showed a very telling slide talking about the availability of opioids, and I noticed on her slide that the opioid usage per capita, Canada was above and beyond everyone else, with the USA falling just slightly behind. So since 2000s, there's been a real strong push to reduce the amount of opioids, and so when we crack down with CDC guidance and everything, there's been a vacuum to try and find something else that will fill that hole. And as we know, the gabapentinoids have come under some scrutiny recently with the problem with addiction and dependence, and so they're looking for another drug. And as I don't know if anyone else has any recollection, but certainly there's no major new drugs in pain medicine that have come along. And so with the legalization of cannabis, it's obviously sparked a lot of interest. Now, I talk about America being an opioid epidemic, but certainly Ontario, the province where I'm at, has major problems with opioid use, mainly because 90% of Canadians actually live within 100 kilometers of the US border. And so it's, again, something else we're trying to find an alternative for. So currently, cannabis comes in a few forms. Both, I showed you the medical ones with DIN numbers, but the thing about cannabis and the cannabis products are, if you just know that cannabis is a very fat-soluble drug, you can then use any solvent or thing that dissolves fats and oils and find a preparation for it. So you can have it as a flower, which is the dried buds. You can have it as a vape pen, where it's suspended in polyethylene glycol. You can have it as an oil. You can have it as edibles. You can have it as something called shatter, which is butane hash oils. And then if you go on you only need a quick internet search to know you can have it in tinctures, rubs, creams, capsules, transdermal patches, you name it. People have tried different forms. And again, this makes it very difficult to say that this one drug makes a difference because of this wide array of availability in the forms of the product. Because it is legal, though, we do have some good data coming out in cannabis. In Canada about cannabis. The Canadian government actually does surveys and can actually find out how much cannabis usage is going on and what drugs and how much is being used. So this is data from 1920, which is the most recent data that's available. And as you see, about 29 to 30% of people, patients or people in general, sorry, not even patients, have tried cannabis in the last 12 months. Most of them take it occasionally, but there are those enthusiasts who do take it on a daily basis. In terms of how much is used, most people buy it from a legal storefront, although it is legal to now grow up to 4 cannabis plants per household in Canada. So people do get it from friends, other legal sources. Before legalization, we also had the odd situation of having non-federally mandated reservations for First Nations as well. And so a lot of those were selling cannabis products. It just didn't have the same logistical provenance, so it's very difficult to know what was being served. But our closest one here is about 20 minutes away. It's the Mohawk territory in a place called Deseronto, and they've been selling cannabis and cannabis products with lots of stores, as well as cheap gas because they don't pay tax on the fuel. So it's been available even though it's not been legal. It's been available in non-legal outlets for quite some time. Generally, the average amount people smoke in terms of the dried flower is about 1 to 2 grams a day, and people spending about $70, so about 40 pounds on cannabis products per month. So, as I mentioned, it's difficult to really say, does cannabis help with pain, because what is cannabis? And I've said it's a multifactorial medication. If you smoke it or vaporize it in a pen or dab it, which is where the people use a hot nail to heat the shat or the butane hash oil to vaporize it, then the effects are immediate and they last up to 6 hours. If you eat it in edibles or in brownies or take it as an oil, then the effects take a lot longer, up to 2 hours, and the effects are longer. So it's that classic sort of large peak versus slow peak of any drug that we use. In general, so as I said, we do prescribe it, and there are medical clinics, and this is more of a remnant from when it was legalized, when it was medicalized, prescribable, but before it was legalized. There's still a lot of clinics open in Canada because, well, there's 2 reasons. One, there's a lot of people who don't know how to take it, and the outlet shops aren't allowed to tell you how to take it or give advice on what to take. So there has to be an alternative sort of source, and a lot of my patients, especially the older ones, want that doctor's guiding hand to be able to help them into prescribing and how to take it. The other option is also the Veterans Affairs, so people who served in the armed forces, they get a very comprehensive drug plan, and cannabis is actually part of that, used for PTSD and trauma. So, and there's no upper limit for them, and that's covered by, their costs are covered by the Veterans Affairs. And so a lot of the cannabis clinics now are used mainly for those people. When it's prescribed as well, it's usually prescribed in a clinic by someone who exclusively does that. And so I don't do it myself in the pain clinic because there are people who are much better at it. The prescription is usually very vague. It's not like a drug where you give a milligram dose and a frequency. It's a general dosage of a flower, let's say 1 to 2 grams a day. This is how much you can take. And then it goes off to the supplier, the growers, and then they interpret that prescription how they see fit, and then that actually gets sent directly from the supplier directly to the patients via the Canada Post delivery system. More and more with our understanding of what seems to work best, and this is very much anecdotal and evidence, we are finding, again, because we don't want that high peak and trough of a drug that's smoked or ingested with a quick onset, we're finding the oils are the most appropriate thing for pain patients or patients who want it from a more medical point of view than a recreational point of view. So yeah, I've covered that. Now, again, the benefits of being in Canada at the moment, because of its legalization, is that the Canada government has issued these guidance, and this was all on their website as of last week, showing that they do have a summation of the health term benefits and the effects on the brain, about what cannabis does to you. And this is, so if anything, I would say this is sort of the official stance of the Canadian government. So they've obviously looked at the short-term benefits. It makes you feel, can make you feel happy, can give you a relaxed experience, but there are some negative sides as well. People have bad trips. It can cause confusion, sleep, irritability. And obviously with impairment, one of the main issues that we've had is because it's a drug that's so fat soluble, it stays in the system for a very long amount of time. Drug testing in hairs and things can last for months. And so it's very difficult, other than subjective tests, to know if someone is acutely intoxicated or not. Unlike alcohol, where you can check a blood concentration measurement, here you're always going to be positive, and the actual amounts is very difficult to say. So they have to, so if people get suspected of being intoxicated whilst driving, it can only be through subjective measures that they can be identified. The Canadian government does recognize that there are long-term risks of cannabis, and it even talks about reduction in IQ and intelligence, the ability to make decisions, affects memory and concentration. All things you'd expect, and what you maybe even if it's a superficial understanding, you'd think that cannabis does. Now this is a bit controversial, because the Canadian government does actually say that you can have an addiction to cannabis, and I'm wondering if this is a misinterpretation of sort of what the difference between dependence and addiction is. But it certainly does have a level of dependence. There's also, if you ever want, I'll put the link on here, and hopefully you have the slides available. It does actually look at, for healthcare workers such as myself, how to use cannabis in our practice. It suggests them, it's not very, again, it's the same as all the other evidence that we've seen. It's not very cut and dried. It suggests that there may be models that suggest pain relief and have some analgesic effects, but it's by no means a cut and dried answer. Again, it harks back to some of the original studies saying that things like neuropathic pain, or there may be some benefit, but again, this is by no means reproducible or quantified. They have given us a flow chart to try and help decide whether we should be looking at the cannabis products. And again, it's the way, if you look through this, it really does just show that it's a number of tiers back from your standard over-the-counter analgesics, mainstream neuropathic pain medications. So it's kind of something to be thought of after trying all our standard therapies. And it's not without its risks. Now this is there is main issues coming out, because obviously it's a younger population that seem to be using cannabis recreationally, and this isn't just related to cannabis, but also the nicotine vape pens. There's a large number, and I was speaking to one of my thoracic surgeons the other day. A large number of alveolitis being caused by the polyethylene, the smoke coming from these vape pens, plus vape pens explode from time to time as well. So there are all these other ancillary issues with ingestion of cannabis products. So I just thought I'd quickly go over sort of the anesthetic considerations as well. So looking at it from a perioperative point of view, so what do we do when people come into our institution who are on cannabis, and how does it affect the anesthetic that we give? This was probably one of the best papers I've seen recently, from 2019, looking at the perioperative care of cannabis users. And it really does show that there is a multi-system effects from cannabis, both from an acutely intoxicated view, but also from a chronic user perspective. So if you are a new user, then or you're acutely intoxicated, then it's, you know, it sort of stimulates you sympathetically, so you get tachycardia, systolic hypertension, you can get arrhythmias, and there have been instances of coronary spasms as well as reactivity of the airways. Chronic users still got the reactivity of the airways, but it's kind of the other way. Those initial factors are almost burnt out. The patients become resistant. One thing that from a surgical point of view, the temperature regulation changes, so they can get worsening hypothermias and shiverings. Other drugs, it can interact, and so it can actually prolong the action of drugs like ketamine, but all equally, because it's so fat soluble, other drugs that are fat soluble may cause interactions there, and it can last in the systems up to 5 days after the last exposure. So it takes a long time for it to leave the system. One of the most important, from this paper, one of the striking things that I found was that the cerebrovascular effects, there was a 2.5 to 3-fold increase of cerebrovascular ischemia in young users compared to even tobacco smokers, which I thought was sort of underreported or under-recognized, and that it can increase your systolic blood pressure, which obviously if we're dealing with patients who need blood pressure control, it could be a factor. And as we expected, propofol, cannabis users usually need significant higher amounts of propofol. In terms of opioids, the perioperative use of opioids doesn't seem to, it seems to vary. Now, and I'll come on to that in a second with another paper. The Cochrane Library came out with systematic review. This was more recently, and this paper again said the jury's still out. Now, one other proviso I would probably say is when people are looking at the systematic reviews, I think we have to remember that all the papers that are being swooped up together by these systematic reviews probably include a lot of patients who are cannabis users, who were in a pre-legalized study. So a lot of them are looking at people who are on concomitant drug use, and it uses studies that were maybe looking at people who are taking recreational cannabis as opposed to these more chronic-based routes such as the oils. And so, and they weren't specifically looking at pain, they were usually secondary outcome measures. So it's just something to be aware of. And I think it's something that will improve now that America and Canada have legalization of the medications. So going back to pain in the perioperative period, there was this one study that I thought was quite interesting, and this showed that in orthopedic surgery at least, the actual requirements of opioids is very similar in the different groups, but the cannabinoid users generally were a bit twitchier and more anxious. So they had poorer sleep quality, and they had higher pain scores at rest. But this didn't translate to increased use of opioids, although you can imagine how these factors could lead to increased opioid usage depending on prescribing trends. So, so going back to about pain management and chronic non-cancer pain, going back to this article I showed you at the beginning with the numbers needed to treat of 24 and the numbers needed to harm of 6. This paper was a systematic review of the studies up to that point. Now, it looked at 91 studies, and it found significant benefits in chronic non-cancer pain to a level of a reduction of 30% of pain. It did not find a significant evidence for anything higher, such as 50% of pain. But then, like I said, the numbers needed to treat numbers were very high, and so it doesn't really lead it to being that golden bullet that we were maybe hoping for. So a little bit about how we are using it and how we're finding it being affected. So currently our APMS, our acute pain servicing at KGH, where I work, we're finding that those people who are on who are taking cannabis users normally, because it's so highly lipophilic, it doesn't really, people are coming in and out for day surgery, it's already in the system, it stays there. And so we're not finding any issues with it in terms of withdrawal in the short term. Because people like to smoke it or vape it, obviously there are restrictions there. People are still allowed to bring in their oils or their gel caps if they have their own supply, but they're not allowed to take in edibles because the variability of the dosing in those is just too high. Because there is no DIN number or drug identifier number for cannabinoid or cannabis products, other than the 3 I mentioned at the beginning of the talk, it's not available in pharmacy. And so the only one that we can really replace is the nabalone, but we can't replace the CBD part of what they take. And usually it's the THC that is the part that's the psychotropic part that people maybe withdraw from the most. So it's for people who are in longer term, then we are finding nabalone is probably the poor man's substitute until they go out back and take their own supply. So in summary, I suppose looking at it from an acute and a chronic point of view, really the answer is the same. At the moment, we are using it, and the numbers, as you saw, are quite high in terms of the users in the community. If people come into the chronic pain clinic, often we talk about the oils, mainly because of their pharmacokinetics compared to vaping or smoking. But there are no clear answers, and mainly this is because it's like calling all sweets one thing, whereas really we know there's so many different types, variations, and it's the same thing with the cannabis products. It doesn't help that there's a huge commercial drive as well. In fact, about 20 minutes north of Kingston, there's a place called Smith Falls, and the rapper Snoop Dogg has just has got strong links with them. So there's a huge popular culture drive, and there was a huge buzz about 2-3 years ago about cannabis becoming the next big sort of get rich quick sort of area. So there's a huge sort of monetary and social drive to the marketing of these products. And because they're so varied, it's very difficult to, and because it's falling under the the tobacco and alcohol laws, it's very difficult to therefore have sort of pure medications that are consistent and follow a more pharmaceutical guidance as opposed to a liquor license. So I think we would say that it's not as benign as we would want it to be. And it's certainly not an opioid replacement that we hoped it would be. And the jury's still out in terms of where it really fits in place. But it certainly is after the standard treatments that we use and we all use in terms of neuropathic pain medications at this present time. So that's my talk. Sorry, Sanjeev, I think you are muted. I think you're still muted.
Yeah, I'm okay now. Thank you, Chris, for the excellent presentation. I've learned a lot about cannabis today, I should say that. Now, there are some questions. Does the analgesia that cannabis provides depends upon the ratio of the THC and CBD in the product?
Yes, absolutely. Yeah, absolutely. And at the moment, there's no, as far as I've been trying to, I keep looking at papers. There's nothing that really, I know there's no papers that really talk about CBD and THC being, there's no clinical trials that we've done. We actually were in our clinic, because like I said, we are about 20 miles south of Tweed, which is one of the main cannabis growers. They actually wanted to start a clinical trial looking at variable CBD THC dosing for patients looking at fibromyalgia, but unfortunately, because they'd be great, they really wanted to have a DIN number and become a pharmaceutical drug as well, because then it would be prescribed more, and there'd be a second source for their usage. The problem is it's just not because what you take. There's so many variabilities in terms of getting a consistent supply, even from the suppliers. Ever since the cannabis clinics opened, the legal ones, there's obviously had to be a provenance. So the supply chain is more strict, or it has those quality controls as you'd expect from a liquor store. But there's just so many variations, and like I said, so many different types. There's no sort of clear evidence. Anecdotally, I would say that CBD only oils seem to help people a lot in terms of it not they don't like, it's not an analgesic in terms of if you had a pain scale rating of 1 to 10, they would say my pain, it's not a 6, it's a 6 out of 10. It's still a 6 out of 10. But what I find is I just care about it less. It's a 6, as opposed to it's a 6. And so these patients are, it's not a traditional analgesic, and maybe we have to not use traditional methods to, like 30% pain reduction, to decide on it.
So it's more of a psychotropic, or it affects the psychology, the perception of the pain rather than the real pain.
Yeah. I mean, CBD1 does have the CBD1 is the main one where we're targeting. CBD2 is on immune receptors, and there's thought about anti-inflammatory and even anti-cancer sort of treatments. Again, that's all sort of theoretical, but it certainly does seem that the THC is generally, when it's prescribed, it'll be CBD during the day when people just want to get on with things and care less about their pain, and then THC at the end of the day, which really helps with sleep. And it's the THC helping with sleep, which, as we all know, has that knock-on effect of having a feeling of well-being if you get a good night's rest.
Okay. Now, the question is, cannabinoids can be associated with dependence, so can opioids. Is there any difference in the rate, or maybe the possibility of a dependence with either opioid or cannabis?
I don't know specifically if there's a. I mean, are you talking about the two together? What's the question?
No. Comparatively, is cannabinoids more dependent? Can patients become more dependent on cannabinoids?
Got you. I think
opioids.
I think cannabinoids are less. My understanding is it's less dependent, mainly because of, if you're a chronic user, there's this large lipophilic nature to it. So it stays in the system for a long time. So you have a natural wean if you stop it, as opposed to the opioids, which, the effects happen as soon as the drug leaves the system. One thing that we are seeing a lot of is a new, it's a well-known but a relatively new thing of people who are high cannabis users. They're coming in with these new factors. There's this one thing called cyclical vomiting syndrome, where a lot of the emergency doctors are seeing people who are on cannabis who just keep having severe abdominal pains. And it's something to do with I think it's something to do with the valine receptors in the skin. And the only thing that gets rid of that pain is severe heat. So you'll get these people who stay in the shower and you have hot water on them for hours because they can't, because of these cyclical vomiting episodes. And the only treatment is stopping cannabis, which they don't want to do. So they have lots of showers.
Okay. And is there any experience of using cannabis in palliative care?
Yes, but again, it's not in terms, like I said, the drobanal nabiximols, the Sativex has been used in cannabis palliative care. I think because it's one of those things that it's kind of so many layers back, and it's usually with opioids as well. And the chemotherapy with nabilone has been used in chemotherapy anti-nausea. There's probably a Venn diagram in terms of the effects, but I don't know of any specific papers that look at that. As you can see, it becomes a rabbit hole in terms of the usage.
There's also some suggestion by one of the attendees that is there any way, now that in Canada it is legalized, and there is a way of sending this by Canadian mail and other proper channels, is there any way of measuring patient-reported outcome measures in patients who are taking this type of medication?
Yeah, there is, and that's where, like you said, the problem is, if, as with any study, you say, what are you taking, and what are the effects? So the problem is it's because even though the prescription probably said 2 grams of cannabis a day, there's sativa and indica, which are the two main ones. How much THC is in there is variable, and how much the doses are so variable that's very difficult to. And I know one of the main problems we have with the Veterans Affairs is that there is, because they get an unlimited supply at no cost, there has been increasing problems with diversion of that medication away. So, like I said, there is that, like that Canada survey showed that there is the usage, and I think there is going to be part of that where they look at pain reduction, but there's no papers, as far as I'm aware right now, of drug use or the pain reduction.
One last question from me. After that, if the faculty wants to ask any question, is that okay with you, Chris?
Absolutely, yeah.
Yeah, it's an interesting topic for all of us. Now, the last question is, do you think in future cannabis products will replace opioids?
Well, I mean, cannabis, I would say cannabis has been around for as long as opioids. Okay. So the reason, I mean, it's very, I mean, again, whilst researching this talk, it's very interesting why cannabis got, there's a theory that cannabis got made illegal probably around prohibition times in the US, mainly because of lobbying by the tobacco companies, because they were seeing it as eating into their profits. But I mean, before then, cannabis was well used, you know, in the same way that you look at we've all seen the pictures of old cough syrups having cocaine, heroin, and cannabis in them. And so a lot of these were obviously unregulated. I think if looking at the patients coming in, I would say that cannabis, as I said, doesn't have that analgesic benefit. Personally, I think in an acute setting, opioids are still by far the best thing for an acute pain management system, and really have very little place ongoing other than palliative care in a chronic setting, certainly for neuropathic pain. Whereas cannabinoids, I think we need to change, as we are doing, and I don't know how and this is always interesting how in the UK and India, how people are actually defining success in terms of benefits. Certainly, even though we still measure it that 0 to 10 like a pain score, we're using functional assessments as opposed to, so that's that very basic 1 to 10, which has kind of been the gold standard for many years. And so to assess someone's gold standard, a function, then makes it very difficult, because multifactorially, we are also talking about whether it helps them get their, certainly in the chronic pain clinic, whether it helps them with their, you know, insurance, whether it helps them with that car crash they had, whether it helps them with their employee disability thing, and, you know, or the secondary gain of having family coming around. So we all know that multifactorial effect of function versus actual benefit, and I think that's going to be a very difficult thing to tease out.
Well, thank you, Chris. Any of the faculty members, do you have any questions? You can unmute and ask Chris if that's okay. I know we are overrunning, but it's a topic which we get less to hear about. John?
Chris, I just want to say, so thank you so much for spending, giving us your time to do that talk. It was really enlightening. I thought, like, cannabis isn't that great. You've given us a really kind of balanced view on cannabis, and I think it was really, really good to hear. But I think we should probably kind of come to close the meeting, Sanjeev. I think if that's
okay, great. Thank you, Chris.
Thank you very much.
Before I hand over to John, who is the organizer, I would like to thank John for taking all the trouble to communicate with everybody, organizing the program, coordinating all of us. He's put in a lot of effort. I would also like to thank the Pain Relief Foundation from Lorraine and Julie for helping us with all the administrative aspects, registering everybody, and what else can I say? Everybody has been excellent. So let me hand over to John. You are the organizing chairman. Please.
I don't want to say much else, Sanjeev. I just really want to, so thanks a lot to you as well for helping organize this meeting, and everyone else in the group, and especially to Lorraine and Julie in the Pain Relief Foundation, and all the delegates for all the your attention and your questions. And I think that made it a really good day, an interactive day for everyone. So that was great.
Excellent.
Thanks.
Now we'll have a business meeting.